Okay, good morning, everybody. Dr. Rafich here from Triage. It is Wednesday, December 4th, 7:41 a.m. Pacific time. I'm in a hotel once more, so sorry for the background. We're going through this issue of JAVMA. It is from February 15, 2017, and we're talking about the anesthesia case of the month. Okay, this is a 5-month-old, 6 kilogram intact male chow chow. He was planned on having phacoemulsification surgery for the treatment of congenital cataracts. So cataracts is when there's, oh, thank you for the hearts. Cataracts are when there is hardening of the lens in the eye, and if it progresses enough, it will causes a problem with vision of the eye. Congenital means that the dog was born with it; it was not acquired. Phacoemulsification is a surgical procedure performed by ophthalmologists where they make a small incision into the cornea and they literally will dissolve and suction out the cataract. So basically, remove the lens. The dog was pre-medicated with buprenorphine, 100% oxygen, propofol, diazepam, oral tracheal intubation using a reinforced cuff tube. Reinforced cuff tubes. So there's endotracheal tubes that are just silicone or plastic, or whatever they're made of, and there's others that have like a metal ridge or rim around it, like a spiral fashion, and those help prevent kinking of the tube. It was connected to a modified Mapleson D breathing system, also known as the Bain system. The pet was placed in dorsal recumbency. They had a capnogram on it. This measures the end-tidal CO2, carbon dioxide, of the patient. They noticed that the capnogram stopped working. They started manual ventilation. Then they found that the endotracheal tube was kinked, rostral to the epiglottis, causing an obstruction. The reinforced endotracheal tube was replaced with a non-enforced cuffed tube with a Murphy eye. They gave the dog atracurium, which is a neuromuscular blocker. It causes paralysis, and ophthalmologists will frequently use that because of the involuntary movement of the eye. Even with anesthesia, the eye will still like move. So they give that to paralyze them, but then they have to be on mechanical ventilation. They had a peak inspiratory pressure of 11 centimeters of water, respiratory rate of 12 breaths per minute, inspiratory to expiratory time ratio 1 to 3. Anesthesia lasted for 180 minutes with no additional complications. 2 hours after, they found a decrease in blood pressure. They bolused some hetastarch, which is also hydroxyethyl starch. At the completion of surgery, mechanical ventilation was discontinued. The patient was breathing spontaneously. The end-tidal CO2 showed that the patient was tachypnic, 68 breaths per minute. They gave diazepam to avoid post-anesthetic excitement. 30 minutes after, the patient became dyspneic, cyanotic mucous membranes, pulse oximetry, which measures SpO2, was 80%. And you want it like 95% and above. Butorphanol was given, oxygen. Then they heard pulmonary crackles in the lung fields. They performed radiographs that showed pulmonary edema. They gave furosemide, which is also known as Lasix. It's a diuretic. 10 minutes later, the dog arrested. They tried CPR and was unsuccessful. They did necropsy on the dog. Severe alveolar hemorrhage, hyaline membranes over the alveolar septum, and congestion of the perivascular space and pulmonary vessels. These lesions were indicative of severe pulmonary edema with lung injury, probably owing to the high negative pressure related to the airway obstruction. So now we go into the discussion of all this. Endotracheal tube obstructions can be divided into either intraluminal or extraluminal causes. Intraluminal causes, meaning things that are inside the lumen, inside the actual inner diameter of the endotracheal tube, include obstruction of the tube with mucus, blood, or gastric contents as a result of pneumonia, hemorrhage, or aspiration. Airway secretions can also do it. Foreign bodies such as teeth, dental implants, granulation tissue, or even beans are rare events encountered in human patients. The use of an endotracheal tube with a small internal diameter increases airway resistance, causing increased respiratory effort, resembling that associated with partial airway obstruction. When you used a reinforced tube to prevent kinking, they have a smaller diameter because of how thick they are. Extraluminal causes are kinking, usually due to the patient positioning or cervical manipulation. Compression of the tip of the tube against the tracheal wall can cause extraluminal obstruction. Herniation of the cuff is a rare complication, overinflating the cuff. In our opinion, for this study, this problem was likely related to re-sterilization of the tubes rather than to the gases used. Defective manufacturing of the endotracheal tube was suspected. These types of obstructions can be classified as intraluminal or extraluminal, depending on the manufacturing defect. Once an obstruction occurs, the patient's peak inspiratory pressure will increase, and manual or mechanical ventilation may become difficult or impossible. End-tidal CO2 and oxygen levels may initially be unchanged if it's a partial obstruction. When there's a partial obstruction, deflation of the endotracheal tube cuff and repositioning of the tube may be attempted. If available, suction of the tube lumen and fiber optic examination of the tube might be helpful. Removal of the obstructed tube and intubation with a new tube should be performed. So negative pressure pulmonary edema is what they're calling this. To our knowledge, this is the earliest description of an upper airway obstruction leading to pulmonary edema in dogs. Breathing spontaneously against an inspiratory load was published in 1927. In human patients, the first description of post-obstructive pulmonary edema was in 1973, a pediatric patient with shock. Negative pressure pulmonary edema can be divided into two types on the basis of the timing of the obstruction that causes it. Type 1 negative pressure pulmonary edema appears after an acute obstruction of the airway, like angioedema, foreign body, tube obstruction, or laryngospasm, resulting in a forceful inspiratory effort against a closed airway. Type 2 negative pressure pulmonary edema occurs following surgical resolution of a chronic airway obstruction, such as laryngeal mass. In human patients, the incidence of negative pressure pulmonary edema has been reported to be between 0.05 and 0.1% of all anesthetic procedures. Type 1 is 9.6 to 12%, and then type 2, 44%. Type 2 is way more common, it seems, in humans. Young, healthy subjects can generate high levels of negative inspiratory pressure, up to negative 140 centimeters of mercury. This high negative pressure is transmitted to the intrapleural spaces, increasing venous return to the right side of the heart and pulmonary venous pressures. At the same time, perivascular interstitial hydrostatic pressure is decreased, favoring the movement of fluid from the pulmonary capillaries into the interstitium and alveolar spaces. With the latter mechanism, the mechanical stress associated with respiration against an obstructed upper airway can rupture alveolar, epithelial, and pulmonary microvascular membranes, resulting in increased pulmonary capillary permeability and protein-rich pulmonary edema. Sympathetic stimulation also creates a hyperadrenergic state that causes pulmonary hypertension and peripheral vasoconstriction. This condition and the concomitant increase in venous return further exacerbates pulmonary edema. The hypoxemia decreases myocardial contractility, increases pulmonary arterial resistance, thus increasing pulmonary capillary pressure and worsening the edema. Negative pressure pulmonary edema has been reported in dogs, cats, and horses. Most causes in human patients are uncomplicated and resolve in 24 to 72 hours. 5 of 17 dogs and cats and 3 of 5 horses had a fatal outcome in previous studies. Negative pressure pulmonary edema usually occurs rapidly following the removal of an obstruction. However, delayed onset has been reported. Tachypnea, tachycardia, hypoxemia, hypercapnia, and the presence of frothy fluid in the airways or endotracheal tube are clinical signs of pulmonary edema and can be an indicator of negative pressure pulmonary edema. Radiographs include diffuse interstitial or mixed interstitial and alveolar infiltrate. Ultrasound can be used in human patients with a sensitivity of 94.6% and a specificity of 96.1%. The treatment of this condition, maintaining patency of the patient's airways, providing oxygen, providing positive and expiratory pressure or non-invasive positive pressure ventilation. 50% of people reportedly require continuous positive airway pressure, and the treatment of this condition in humans is generally successful. Exposure to 100% oxygen can have cytotoxic effects owing to the generation of free radicals. These can lead to pulmonary dilation, vasodilation, and atelectasis. In cases where supplemental oxygen is needed for more than 12 hours, the inspired oxygen fraction should be reduced to less than 60% to avoid adverse effects. In patients that have received opioids, naloxone, which is an opioid reversal agent, should be administered if the pulse ox is less than 90% to reverse respiratory depression. If carbon dioxide is over 50 millimeters of mercury, and the arterial oxygen concentration in the arteries is low, less than 60 millimeters of mercury. This indicates decreased tissue oxygenation, and mechanical ventilation with positive and expiratory pressure will help improve the oxygenation. If the patient is hemodynamically stable, administration of diuretics in addition to mechanical ventilation and oxygen can be appropriate. However, the use of diuretics is controversial. Another study of this condition in 5 humans without the use of diuretics showed great improvement for 3 of the 5. Another study reported that diuresis may not be helpful in the case of a sudden shift in fluid of the pulmonary interstitial, as is patients with this condition. Administering diuretics in these cases can increase intravascular volume depletion, worsening hypotension, life-threatening hypovolemic shock, especially in patients that cannot compensate for fluid loss. Despite this potential complication, diuretics are often administered to patients with this condition in an effort to decrease intra-alveolar fluid and improve ventilatory status. In hypovolemic and dehydrated patients, you want to avoid diuretics until intravascular volume is normalized. After administration of diuretics, patients should be monitored in case volume resuscitation is required. Postoperative pulmonary edema may be caused by anaphylaxis or anaphylactoid reaction to drugs, although other signs such as hypotension, bronchospasm, and hives would be expected. Volume or pressure acute lung injury can cause or contribute to postoperative pulmonary edema in manually or mechanically ventilated patients. Fluid overload as a result of fluid maldistribution can cause pulmonary edema in patients with hyponatremia or receiving hypotonic fluids, and in patients with cardiac disease. Other causes of postoperative pulmonary edema include neurogenic and cardiogenic. Brachycephalic airway syndrome is a possibility. Neuromuscular blocking agents also can be a possibility, and residual chloralization might have contributed to the postoperative hypoventilation and hypoxemia, worsening this condition. Histopathologically, the pulmonary lesions in this patient resemble those in another study that include multifocal intravascular hemorrhage and hyaline membrane formation in the alveoli. Endotracheal tubes can be manufactured from polyvinyl, chloride, silicone, or red rubber. Red rubber are opaque and they can kink, but they're easy to insert and can be reused. Polyvinyl chloride and silicone are similar and are less prone to kinking, but because they mold to the shape of the patient body temperature as it warms. The main problems with silicone tubes is that they are expensive and they may require a stylet to insert. Reinforced or armored tubes are very rigid because they have an internal metallic spiral with a thicker wall. These tubes are not prone to kinking. Potentially disadvantages of those tubes, though, is that if an animal bites the tube, it can be permanently obstructed. Furthermore, these tubes are manufactured with a smaller internal diameter than standard tubes because of the thickness of the wall. These tubes may also have a sealing cuff that prevent aspiration of regurgitation or foreign material and avoids dilution of the inspired gases with room air. High volume, low pressure cuffs require high volumes to be inflated, but the pressure is distributed across a larger tracheal surface, avoiding tracheal ischemia and necrosis. Low volume, high pressure tube cuffs provide better sealing of the trachea, but increased risk of tracheal damage. Endotracheal tubes may have a Murphy eye, which is an oval hole in the tip that allows gas flow even if the tip hole is occluded. The endotracheal tube may have moved down the trachea during flexion of the neck, pushing against the carina and causing obstruction. Consequently, it's important to measure the length of the tube to be used and adjust it accordingly to the patient. Nonetheless, when dealing with reinforced tubes, this may become a problem. Reinforced tubes cannot be cut. I didn't realize people even cut these tubes. That's crazy to me. Thus, part of the tube can protrude outside the mouth. If the length is not measured before intubation, the tip of the tube can travel deeper into the carina. In the author's opinion, polyvinyl chloride or clear silicone tubes with a Murphy eye should be used if no contraindication exists, as they will mold to the patient's position and the 2 orifices will prevent obstruction of the tube. For procedures during which kinking of the tube can occur, reinforced tubes should be used. And that's it. There you have it, folks. That's a great reminder of something that we take for granted, which is endotracheal intubation, and all the different reasons why there would become an obstruction of the tube. So I don't know if the case turns to a medical board case or what, but clearly it's It's not a common scenario that this happens, and I'm glad they reported it. And that comes out of Barcelona, Spain. So, okay, everybody, thanks so much for watching. We'll be back again tomorrow for another one. I will be traveling, so I'm not sure what time it'll be. So it's a possibility that I can't do it because of travel. We'll see, but we'll see. Thanks so much. Thanks to those who are watching, by the way, and thank you for the hearts. Bye.